Hi, welcome to our event today. I'm Kristen Schilt. I'm the faculty director for the Center for the Study of Gender and Sexuality at the University of Chicago. And this is our third virtual panel that is revisiting some of the key themes of the American Journal of Sociology special issue on the status of women in 1973. I'm going to introduce all of our panelists, but first I want to say, this is sort of a bittersweet panel since 1973, of course, is the year of Roe v. Wade. And now at our 50-year anniversary, we're looking at a post-Roe landscape. So certainly not something that I think the authors of the 1973 issue, who had a lot of hope about what was going to be coming, would have imagined. So I'm extremely excited to hear from our panelists today. So let me introduce everybody. We have Carole Joffe, who is a professor in advancing new standards in reproductive health at the University of California, San Francisco. We have Ophra Leyser-Whalen, who is an associate professor of sociology at the University of Texas, El Paso, and Tamika Odum, associate professor of sociology at the University of Cincinnati. And our panel will be moderated by Theodora Hurley, who is a PhD student in sociology at the University of Chicago. So I will hand this over to Theo. Our structure will be, our panelists will have a conversation for about 45 minutes, and then we'll open it up to questions from the audience. And at any time, you can put a question, you can type it into the Q&A, and we encourage you to do that as sooner rather than later. So thank you very much.
Great. I want to say thank you to all of our panelists for being here today. I think this will be a really fantastic discussion. And thank you to all the audience members who came out to listen and hopefully to ask questions. So to start off, I would love it if you could all tell us a little bit about your research. And for this question, we'll go Professor Odum, Professor Leyser-Whalen, and followed by Professor Joffe.
Thanks so much for inviting us today, particularly for inviting me today. It's always, given the landscape, oftentimes our work can be hard and challenging and sad. However, in being able to talk about sort of the hope of the future and what we're doing to sort of manage these things is wonderful. So thank you for having me. So my current research is particularly centering Black folks and the experience of Black folks who are seeking abortion care. The project is titled Transforming Access, Black Women's Experience Seeking Abortion Care. And what it does is it does two major things. It looks at structural racism, and it looks at how structural racism informs the different reproductive decisions that Black women make. It also looks at how medical mistrust operates in terms of access. So how does medical mistrust operate in the lives of Black people, and how does that inform the different reproductive decisions that they make? In addition to that, it's really important because we're specifically looking at Ohio, and we know that Ohio is a highly restrictive state. And so the policies that are there are critical for us to examine as we're understanding the experiences that Black women are experiencing as they're seeking abortion care. So what we're hoping to do is not only tell the story of Black women and their plight to seek abortion care, but we also want to create spaces where community can feel empowered to lead this work to create healthy communities. We also want to know about the policies and how Black folks are really understanding the policies and what those policies are meaning. But the interesting thing I think that people often forget, even though as sociologists, we know that structural racism exists and that it operates pretty rampant within the reproductive health realm, but policymakers rarely use research to support the policies that they make. And with Black folks in particular, the research is very limited when it comes to that. So even if there was a space for policymakers to look, there's just not much data that can help them create policies and support policies that are directly tied to the people that they serve. And so we hope that this particular research project will help support that and can provide some evidence so that we can have research-based, evidence-based policies that are creating healthy communities. And so that's currently what I'm working on. I work with the Ohio Policy Evaluation Network. And so abortion patient experiences is really the umbrella term that I situate my research under. Thank you.
Thanks, Tamika. And also thank you all for being here and everyone for inviting me. It's being, the post-Dobbs landscape was extremely, it's not surprising, but upsetting. But one thing that's keeping me going is that people are remaining interested, because once, this is off people's radar, then that's really the end. So I'm extremely happy to be here. I'm starting a new research project where I am looking at how abortion funds and other abortion aid organizations have pivoted post-Dobbs decision. And for those of you who aren't familiar with abortion funds, these are nonprofits that help people either fund the actual abortion procedure or travel-related expenses, housing, airfare, gas money, etc. And what I've already been studying abortion funds, but I think what's really interesting in highlighting abortion funds now is that, similar to, I'm going to go to, since this webinar's in Chicago, go to like the Jane Collective in Chicago that was pre-Roe v. Wade, right? They were extremely grassroots organizers. And I don't mean to imply that they were not concerned with the political realm. Of course they were, and, trying to push for good policy. But, Jane, like current abortion funds and other aid organizations, are more taking matters into their own hands. They're less risk aversive than you'll see some like large organizations, like Planned Parenthood. Nothing against Planned Parenthood. I'm on the governing board of Planned Parenthood of Greater Texas. But, it's always interesting to hear legal scholars versus abortion activists, for example, talk about, what's in the realm of possibilities, what envelopes are we going to push? How are we going to try to help people on the ground? And I think, with the Supreme Court that we have now, and some really conservative state governments, like in my state of Texas, policy should be pushed, but I think the real help that people are going to be getting with obtaining abortions is going to be through these aid organizations. And so I just started my interviews, and I'm really excited to see what people are doing and thinking. And like, this is the future of abortion access in the short term, for sure. Thank you.
I'm hearing an echo. I'm not sure what to do about that. I was temporarily bounced off, and I'm wondering.
I wonder if someone can maybe mute Carole's other cars that are on
here. I have no idea why there's 3 of them. Yeah, if that does.
All right, Carole, I think you can mute now.
Is it still at? Well, no, it's still echo. Maybe go on to the next question. I'll leave and come back. I apologize for this. Okay.
Not a problem.
See you soon, I hope.
Great. We'll come back to Professor Joffe once she's able to come back in. So for now, I would love Professor Leyser-Whalen and then Professor Odum to answer and just tell us about how the Dobbs decision is changing abortion access and reproductive care and planning more generally.
Right. I mean, I think unsurprisingly, it makes it harder for people to obtain abortions, particularly people who are already facing other structural inequalities, as far as being able to have a clinic nearby, be able to afford to take time off, afford to take, get childcare, because most people who get abortions already have children, be afford to travel. All of that is getting harder as access is more and more limited. But I would also say it's not just Dobbs. I mean, there's more criminalization coming at both the federal and state levels. Like, everyone's on pins and needles right now watching a case out of Amarillo, Texas, that might make one of the medication abortion pills not legal anymore, not FDA approved, right? And that isn't necessarily related to Dobbs. So I think the whole landscape should be talked about, in that, abortion is continually under attack, and we need to continue to keep an eye on these things because we need to fight this constant criminalization. So Dobbs was just, I'm not going to say the beginning, because attacks on abortion have been going on for years, but it's just like the tip of the iceberg in some ways. So I think not only Dobbs, but everything else is not only making access harder, but planning harder, because how do you plan for, the next disaster and the next disaster and the next disaster? And I'll hand it over to Dr. Odum.
Yeah, it brings up a good point too, especially around criminalization. And we know that Black and brown folk are more likely to be criminalized than other groups. And so therein lies a larger structural issue about how this is actually larger than just abortion access. And so I think the other idea around access is that we are ultimately losing access. It's not a matter of if, it's a matter of when. And, the Ohio Policy Evaluation Network has done some more recent studies that looked at abortion utilization pre and post Dobbs. And we can already see since, August of 2022 compared to April of 2022, there's 6% fewer abortions. And so people are not receiving the care that they need and they want. And that is extremely, extremely problematic. When you're thinking about just the emotional landscape that's there, it's time consuming, it's emotionally draining, it's logistically challenging, it's expensive to access. I'm thinking about Ohio in particular, and when we lose abortion access, the nearest state that folks here in Cincinnati will likely have to go to will be in Illinois. And so when you think about the cost of travel that's then there, it's insurmountable. We're talking close to $1,000, and folks who are making minimum wage, working class to middle class, who may be making $40,000 to $45,000 a year, you're talking about a week's worth of pay. That's just really challenging, and it's just really hard. The other thing is, like, when you're thinking about this post-Dobbs society, where abortion care is either limited or extremely banned, you can expect that, like, folks will take three different paths, right? Either they'll travel out of state for care, they'll end up carrying the pregnancy to term, or they'll self-source or self-manage the abortion. And so we know that travel, like we just talked about, just has its own set of logistical complexities and financial complexities that are there. And then thinking about, it's this ripple effect for states, right? So we lose abortion access in Ohio. That means Ohio patients are now going to Illinois, or they're going to other states. And the clinics become taxed because of the load of folks that are coming. And then you have longer wait times because more people are being push towards clinics that are outside of their regional area. You're thinking about folks who are in rural areas that already struggle to access abortion care. And now you're adding this additional layer to that. It's really hard. You think about just the laws in general, and it's really hard to even, most folks don't know what the laws are, better yet trying to understand how the laws affect them. And that's both from a provider side and someone who's accessing care. From folks that are trying to carry, like who are forced to decide that they want to carry a pregnancy to term, we know that particularly for Black women, they're 3 to 13 times more likely to die in childbirth. So on some level, it's safer for Black and brown folk to have abortions than it is to carry a pregnancy to term. And so there's that issue that is present there. And then we also know that Black and brown folks are more likely to suffer from complications related to pregnancy and childbirth. And so there lies that issue of post-Dobbs society where access is not available. We're now challenging the reproductive health outcomes and health outcomes in general, because abortion is healthcare. And so what do we do with that? We were talking earlier about, thinking about the FDA approved drug, which is safe and effective, is now going to be challenged. In the past, people could have access to this in certain states where they can order pills online, and now that's threatened. And so you're going to run up with a lot of challenges that are related to that as well. I have a lot more to say, but I don't want to monopolize the time. So perhaps in discussion, we can talk a little bit more about it. But I do think it is definitely a dire situation.
Thank you both for your answers. Professor Joffe, it'd be great if we can hear about your current research, as well as your assessment of how the Dobbs decision is changing.
Okay.
Access.
Now there's just, oh shit, now there's just one of me, and you're hearing me okay. Well, thank you very much for inviting me, and I'm delighted to be with these two very smart colleagues. My research, I'm involved in 2 overlapping projects, both focusing on the provider community. With David Cohen, a law professor in Philadelphia, who's a very smart legal theorist, and a lawyer and a sociologist trapped in a lawyer's body. I mean, we've worked together before. We are now doing a project with the extremely cheerful name of 2022, the year Roe died. We are documenting the year 2022. We are talking to a select group of abortion clinicians, some funds people, some other people. Just talking to them at 3 points throughout the year, how they anticipated Roe going, because everybody did. How they initially coped, and now at the end of 2022, when they've had the 6-month experience, what has that been like? And as you might imagine, what it's been like is extremely difficult, very heartbreaking for those who've run clinics for years. In your state, Tamika, a preterm, if that goes, that's just an honored clinic in this world. And the same with you, Ophra. Some of your Texas clinics have been there forever doing fantastic work. And it's heartbreaking for the people who work there. And one of the less anticipated, or I should say the less discussed aspects of Dobbs, obviously, and I don't mean in any way to minimize this. The biggest pain, the biggest problem, of course, is for patients. But abortion clinics are actually a considerable source of employment in many communities, especially for low income, for people of color who've built careers for years in these places. So the loss of these clinics is really just deeply sad. For the people we've talked to in the legal states, it's what already Tamika alluded to. The new normal is working till 10 o'clock at night in some cases. Just floods of patients. Here in California, which is the most pro-choice state imaginable, our governor set up a task force on the future of abortion, and there's going to be a lot of money to help clinics receive people. The fact is, most people who can't get abortions are in the South or the Midwest. They're not going to travel to California. It's too expensive. They're going to drive the 10 hours, from Texas to either Colorado or New Mexico or Illinois. And I mean, those are the places being impacted. And it's people are rising to the occasion. There's a lot of thought being gone into this, but there's no question that these clinics are being inundated. The other project I want to briefly mention is something called Care Post Roe that I'm involved with a number of colleagues at UCSF. And if there are any clinicians on this call, any doctors, nurses, hospital social workers, what this project is, we've set up a website. It's called Care Post Roe. You can Google it. And we're asking people to tell their stories of how care has been impacted as a result of Dobbs. And as you might imagine, we are hearing unbelievably frightening stories of that I'm sure most of you on this call have already read about in newspapers. People showing up with ectopic pregnancies, being turned away, women having fetal demise. The fetus, yes, it's going to die. There's no question that you will have a viable fetus, but it still has cardiac activity. So no, we can't do an abortion. Anyway, so we're collecting stories of that nature. People are telling their stories in the website if they are willing to be interviewed. Myself and another colleague are interviewing them. So that's the research I'm doing. And I do want to just say very quickly, because inevitably a lot of the material you've heard so far and will hear going forward is very depressing. I mean, it is. There's no getting around it. But I do want to emphasize that the provider community is doing all it can to rise to the occasion. I mean, to get people, patient navigators, getting people from one place to another, people who work in the clinic, not just the doctors, but the medical assistants, everybody working much harder than they used to work, lawyers thinking up very creative new theories. So I don't want people to be totally in despair. There is a social movement out there that's working very, very hard. Now about how has the Dobbs decision changed abortion access? I think my two colleagues here have gone over that very well. Everything has changed. In half the states, you can't get an abortion anymore, or if you're post 6 weeks pregnant, which most people don't even know they're pregnant, then you can't get an abortion. Obviously, and as I just said, in the legal states, there's just a lot more people coming. There's some clinical changes that have taken place. For example, second trimester procedures, which use in states where it's not banned, which use a procedure called dilation and evacuation. Historically, this has been a 2-day procedure. So many people are traveling now that at great cost, that clinicians are experimenting with how can we do this in 1 day. And it's safe. There has been no, as in the words of the medical community, no adverse events. But this is an example of not doing the best thing because of political interference. Ophra and Tamika have already talked about the possible end of mifepristone, which will be a disaster. I mean, a real serious blow beyond everything that we have now. So the provider community is now preparing a misoprostol only regimen. That means medication abortion with just one of the drugs that has been part of the the 2-drug regimen. It works not as well as mifepristone with misoprostol. There are somewhat more unpleasant side effects. So again, it's safe. People will still be able to get abortions. but not necessarily the most effective, not necessarily the least unpleasant for the patients. So Ida exhibit number 850,000 of how inappropriate political interference is, in healthcare.
Thank you all for your really informative answers on that. So how do the state and city level bans on abortion that we're seeing since Dobbs tie into other anti-gender and sexuality policies happening in the US today? For this question, we can go from Professor Odum to Professor Joffe and finally Professor Leyser-Whalen.
Thank you. So I'm going to use more anecdotal information in part because I've been talking to my clinician colleagues and hearing the stories that they've shared with me have really been pretty profound to help understand the larger, broader landscape of how this affects some of the policies related to gender and sexualities and autonomy around when to develop or when to start families and what that looks like and what it means. And I'm thinking, for example, if we're thinking about transgender patients, the clinicians have been saying that they've seen a huge uptick in the number of transgender patients that are coming that are really seeking gender affirming surgeries and in fear that this is going to be something, the post-Dobbs landscape is going to be something that will likely jeopardize access to those surgeries as well. You even have patients that who desire to have both ovaries taken away. And I'm not going to go into the clinical aspect of it because I am not a medical professional and that is not my area of expertise, but something as simple as having to make the choice of to delay menses or take away one ovary versus two ovaries. Folks are forced to make a decision because they're concerned that their access to hormonal therapy will also be jeopardized. And so I think that that's also a real concern in this post-Dobbs landscape. I think this idea around personhood, and particularly in Ohio, is also something that is extremely critical to thinking about the landscape of gender and starting families more broadly. Right now in Ohio, there are a couple of bills that are going around that would define personhood as starting at fertilization. And so if personhood is then defined as starting at fertilization, then that would mean that we would have to reclassify emergency contraception. And so not just emergency contraception, but it also has implications on unused fertilized eggs and IVF treatments. And so this is broader than just abortion access. Like, we really have to understand the larger, broader landscape. So we've got people just having freedoms to access medical care is just really in jeopardize. And people being able to have the right to make decisions about their bodies is also being jeopardized, not just around reproduction, but around all sorts of things. And so I do think that those are some interesting things that are going on as it relates to both gender and sexuality and just the larger, broader landscape of what now in post-Dobbs. It's bigger than abortion.
Yeah, thank you, Tamika. Well, first of all, I completely agree that it's not just abortion. The culture wars are back with us full force. In Ophra State, the attacks on trans people and on parents of trans kids is beyond belief, and I'll let her speak to that. I want to raise the question today with all of you: why are Republicans doubling down? Not only on abortion, but all this stuff. They took a beating in the last election on abortion. That's beyond dispute. Donald Trump himself, not my ideological soulmate, but in this case, we actually agree that abortion, the Republican attack on abortion was very harmful to Republicans. So why are they doubling down? I think it's a fascinating question, and jumping ahead to I think, to what we'll be talking about in a few minutes, what are some of the things people should study? That, I mean, for a political sociologist, this is a really interesting question. I mean, a very quick, and I don't have a good answer, a very quick answer is they need that MAGA base that is anti-abortion. They need the resources of the anti-abortion movement. And they don't frankly have much else. I mean, they don't have, I mean, if you go back to the 2020 election, there was no Republican platform. It was just either vote for Donald Trump or don't vote for Donald Trump. Their platform, as we saw in the State of the Union a couple weeks ago, their policies, cut Medicare, cut Social Security, was a disaster, and they had to back away from that. So really all they have, I mean, not all, but primarily what they have is the culture war on abortion, hating on trans people. You might remember from the Dobbs decision, Justice Thomas raised the possibility, well, if there's no right to privacy, well, maybe there's no right to same-sex marriage. Maybe there's no right to birth control. I mean, Roe was decided on the same constitutional finding of privacy that in the Griswold case found for birth control. So, it is really stunning the extent to which the doubling down has occurred. Periodically, we hear occasionally from some right to life op-ed writers in the New York Times, gee, we should really be worrying now about social provision. But this, I mean, they are saying this to a party that is willing to cut as much social programs as possible. So to me, one of the possible, I don't want to say silver linings, but one of the political possibilities we have is just this obsessive focus on abortion, when it is very clear that we saw in the last election. It is very clear from every poll that's been taken that the American public doesn't like this stuff. Off to you, Ophra.
Okay. Yeah, as far as I agree with my colleagues, and when I think about how do state and city level bans tie into other anti-gender and sexuality policies, I mean, I'm going to answer that, but also into racist and anti-Semitic groups as well, because these are sort of all the same groups that are working. The anti-abortion groups are intricately tied with white supremacist groups. And I love Dr. Carole Mason's work on this. She's at the University of Kentucky. She shows a really long history, including current times, right? Like showing that, for example, a lot of the January 6th insurrectionists were also part of anti-abortion groups. So all of these things are tied together. And I think we saw this anti-gender and sexuality stuff a long time ago. So like right after Roe fell, anti-abortion groups used really sexist rhetoric to get evangelicals on board, because abortion wasn't a politicized issue before that, but they wanted to make it so. And so they were kind of preying on other issues that evangelicals cared about, like women's roles as far as staying at home, and abortion breaking up families and making women into floozies and whatnot. And so I think this rhetoric started a long time ago. It's continuing, and it's because of what Carole was talking about, kind of pandering to a larger conservative agenda, right? Like trying to get more people on board. Because if you just look at abortion, right, the US polls show that over half the people believe that abortion should be legal in some sense. But if you tie abortion to larger misogynist, sexuality, racist politics, you're going to get more people. And you can use sort of these same, I'm going to say in quotes, religious arguments, because it's a very specific religious argument, like trans people are going against the will of God, like as if abortion's going against the will of God. And so all of this stuff is tied together, and fighting racism is also reproductive justice, and fighting for abortion access is also fighting racism and misogyny.
Thank you all so much. Before I pose our final question, I would like to encourage audience members to submit questions in the Q&A box at the bottom of the screen. So that said, where do we most need sociological research today around reproductive justice? We'll go Professor Joffe, Professor Leyser-Whalen, and finally Professor Odum.
Well, abortion is such an interesting topic, and it is the most divisive issue in American domestic policy, that we could spend 6 hours talking about the many interesting questions to pose. In terms of the research that, quote, most needs to be done, which I think is a very important question, I think we have to ask a prior question, and I don't want to bring us down, but I think we have to raise the question, does research matter in this issue? And I who spent 40 years studying abortion, I'm not saying people shouldn't study abortion. What I am saying is that we are now at such an interesting moment where things are so politicized, where we have such powerful evidence already. I mean, it's only 8 months since Dobbs. We know the disaster, healthcare. We know people being turned away with very serious medical conditions. We know, Tamika mentioned earlier about the number of people who wanted an abortion who couldn't get one. She spoke about Ohio. The Society for Family Planning has a project called We Count, and they are doing a national survey of clinics. How many abortions did you do before? How many before Dobbs? How many did you do after? For the 2 months before Dobbs, compared to the 2 months after Dobbs, there was 10,000 less abortions done. So we already know that women are not getting the abortions that they need. The Turnaway study, one of the really most significant pieces of social research done on abortion, this was done by my colleague Diana Green Foster at UCSF. We know what the consequences are. We know that those who get abortions compared to those who don't, those who are denied abortions, poorer, more likely to stay in an abusive relationship, less bonding with the children they have compared to those who did get an abortion. So we already know a lot. And if this were a sane society, a big if, we could take just what I just said, that we know those who get abortions do better, including bonding with the children they have, than those who don't. That should be the end of the story. But of course it's not. So I think the research that cries out to be done, with the proviso who's going to listen, documenting. We know that the poorest people, disproportionately people of color, that's who are getting that is, they are overrepresented in the pool of people who want abortions. We need to document the consequences for them, and it's not going to be a cheerful project.
Yeah, absolutely.
I'm sorry, just one more thing. I think a very, very important thing to study, but which is very tricky, and I'm curious how my colleagues here, what their thoughts are. Some of the most interesting questions now and in the immediate future, especially if they take away the FDA approval of mifepristone. We need to study self-managed abortion. How many people are trying to do it? How many of them are getting arrested? How many of them are succeeding? But to put it mildly, that is not an easy thing to study. I mean, we are studying people doing illegal things raises all kinds of ethical, logistical, practical questions that, and I'm curious to hear the thoughts of the two of you. Yes, Ophra, go ahead.
Sorry, I interrupted you earlier.
No, you didn't.
That self-managed abortion is a great point. I think, you're talking about abortion access and reproductive justice in general, really affecting disadvantaged groups. I think one of the groups that often gets overlooked is incarcerated folks. They really have very few rights with reproduction. I think medical sociologists like to study physician autonomy, which is something that Carole touched on with her work. But I think it would be interesting to highlight what is it like to be a physician now? I know in Texas, physicians are scared of treating people. They're telling people, they're turning them away saying, come back when you're on death's door. I mean, how are you supposed to do medicine that way? I think people focused on policy should keep studying health insurance. I think very few people realize how little, how few health insurance policies actually cover abortion, both private and public. And that includes the military, very restricted abortion for our service members. I think more could be done where we highlight the Hyde Amendment, which is a federal law that says you can't use federal funds for abortion. And then I think similar to what Carole said earlier, in the sort of political science realm, it would be really interesting to see how politicians make their decisions. There's some new poli-sci research out there showing that, politicians listen to their constituents, but they found that constituents tend to speak more conservatively about abortion than they actually feel. And that politicians then are kind of getting a skewed idea of what their constituents really feel and want. And so I think that's a really interesting realm to go into. I'm not a political scientist. Those are just a few ideas. Let's hear from Dr. Odum.
Thank you. So first, I want to respond to Carole's question around self-managed abortion. And when you mentioned it, I had to giggle to myself because I currently have a protocol going through the IRB. And all I could think of was good luck getting that through the IRB, because the hoops that I am trying to go through right now just to study reproductive health in general, including abortion, where folks at the IRB don't even recognize that abortion is still legal in Ohio, and they want to know what the legal ramifications are, asking people who have had previous abortions when abortion was legal. So yes, we absolutely need it. And it's also a struggle because it's how are we going to do it? Because there's so many folks that are not informed about the legal landscape, that are fearful, that are it's a lot of things that are going on. But we definitely need to know, because I think if we do lose abortion access completely and totally, that is going to have to be an option. And so how do we make sure that there's evidence and research that's there to inform folks who are providing care? And so I definitely think that is something that we need to have more research on. It'll be tricky on how to get the research, particularly around criminalization and what that needs or what that means. But definitely think that's an important topic to study. I think before I go into my thoughts, I want to talk a little bit about the difference between reproductive rights and reproductive justice. Oftentimes when we're in spaces like these, folks conflate the two. And so I think for sociologists, we're actually most concerned about reproductive justice, but I just want to make sure that we're clear about what the difference between the two are. So, when you're talking about reproductive rights, you're really talking about reproductive freedoms within the legal system. And so this was a movement, and this is important as well, that was led by middle-class white women. And they were fighting for reproductive autonomy. So that's where the reproductive rights sort of movement rests itself in. Reproductive justice is grounded in this understanding that individual choices and behaviors are not separated from interlocking systems of oppression. And this framework in particular was developed and led by people of color, poor people, and low income people, right? And so this particular aspect always centers the priorities of people who are impacted most. So when Carole was talking earlier about how important it is to look at those communities that are poor, that are people of color, that are in that system, it really is important that whatever sociological research that we do around abortion access is framed through the lens of reproductive justice. And so I took some time to think a little bit about sort of like what sociological literature is missing and how we expand. And so I think this idea around the reproductive experiences of Black and Brown folks is extremely important, but it needs to be community-based that's rooted in sociological thought. And I don't see that a lot in the literature, is really understanding the experiences, but through the lens of folks who are actually experiencing what that is. And that's where community-based participatory research comes in. I think it's also important to look at the different systems of oppression and how they interact with folks' everyday lives and how they make decisions about their body, their sexuality, and their health. Again, that's rooted in that reproductive justice sorts of lens. You know, as sociologists, we are really interested in what do people do, how do people do it, and why do people do what they do. And so when we're thinking about how can we sort of fill those gaps in, these are some of the things that are missing. Oftentimes you'll see research that will make little statements about structural racism contributing to poor reproductive health outcomes, but they never talk about the intricate details of why, the social meaning of why. And so having more literature that really speaks specifically to the how and the why, I think is really, really important. But also this idea around the social meaning of access. So we know that access is not just about like proximity of where can I actually go and get to the clinic. It's about cost, it's about time to care, it's about availability, it's about prevention, it's about all of these different things. But how folks who are seeking the care actually matters, probably more so than the folks that are doing the research that have a preconceived notion about what it means, because these things may mean something completely different. So take, for example, just preliminarily, we've been doing some research for the project that I'm working on around medical mistrust. And we had all of this data about previous data about medical mistrust. What is the definition? How do we measure it? And then we start doing our pretest and we're like, wait a minute, this community doesn't understand medical mistrust in the way that the literature is understanding medical mistrust. And so we need to unpack that more. And so there's some gaps there that I think can definitely fill some gaps in. And I think that it's important to also understand, you know, I can't remember if Ophra or Carole said this, but around policymakers and policymakers, like, they actually don't use research, right? And so like, how do we wish they would a little more than they do now, but like, how do we really capitalize on the experiences of people and empower them to lead this work? I think is extremely important, and studying how that works, whether it's through the lens of social movements or it's through the lens of experiences or whatever it may be. I think that that's just an important contribution that sociology can make to the field.
Thank you all so much. So as we move to audience submitted questions, I invite panelists to respond as you feel so moved. So feel free to not answer a question that you don't feel moved to answer. So to start, what do we know about groups who do not support abortion access? Are they especially good at organizing politically? And if so, in what ways?
Do you want to call people for these questions, or how do you want to handle this?
Yeah, thank you. I think that you three should feel free to jump in as you'd like, in any order.
Well, let me just say the obvious. The question was, are they good at organizing? well, look, they just got Roe overturned. What more do you need? I mean, that yes, they are. It's been an incredibly effective movement, a patient movement. Took them 50 years, but they got there. And how did they get there? I mean, it was not one thing. I mean, it was a it was like an army with many different fronts. There was a cultural front. They stigmatized abortion in every way they possibly could. I mean, I'm not surprised to hear, I can't remember if it was Ophra or Tamika who said people talk to their political representatives more cautiously than they actually feel. Well, that's abortion stigma. There was a very in-your-face, very violent wing of, and there still is, of the anti-abortion movement at the side of the clinics. Depending on how you count them, 11 people have been assassinated, some abortion doctors, some clinic staff, and the most recent incident in Planned Parenthood in Colorado, two friends of patients sitting in the waiting room who were accompanying friends who maybe weren't even there for an abortion. So anyway, we've had, a tremendous amount of violence and harassment at clinics. And we, meaning the pro-choice movement, have also had phenomenally bad luck. The election of Donald Trump by not very much, and his really unprecedented ability to in one term to get 3 Supreme Court nominations. I mean, that I don't think that ever happened before. So it was a combination of very good organizing skill and some really good luck. I mean, good luck that Mitch McConnell is so indifferent to the rule, to the conventions of politics, that he prevented Obama from making an appointment and shoved an extra one through for Donald Trump. I mean, this was bad luck.
Thank you. Do any of our other panelists want to answer before I move to the next question? Okay. Great. So how does anti-abortion also correlate with white supremacy groups' push on eugenics movements that target Black and Brown people? For example, reducing criminal sentences in exchange for sterilization. And this person points out that Black and Brown people are more at risk for those types of trade-offs, since they are more likely to be criminalized.
Yeah, I mean, anti-abortion groups have used eugenics arguments for a long time, and including starting in the 90s with the attack on African Americans, right? And saying, how can Black women get abortions because you're killing your race, and we care about Black folks, and that's why we're saying this. Whereas Black feminists are saying, well, wait, hold on a second. I'm the full autonomous human being here making decision about my body, and it's racist to tell me what to do with my body. But these eugenics arguments are around today. Yes, you're right. They've been used for contraception, telling people, for example, like doctors saying, I'm not going to sign off on you being able to use your Medicaid unless you agree to get a Norplant, right? And that more often affects, I mean, poor people, but Black and Brown folks. And for sure with the incarcerated population, as the speaker or questioner pointed out. I don't know if anyone else wants to say that, but there's like Dorothy Roberts and many scholars have written extensively on anti-abortion groups using eugenics arguments.
Yeah, I'll
Go
just add, it's interesting when you think about anti-abortion groups, oftentimes what anti-abortion groups look like are white, right? White evangelical folks that are pushing the movement. And when you think about the whole eugenics piece, what's missing is that there's not much research that even talks about the role of the Black community in pushing the agenda as well. And it's rooted in the Black church. And what that means, I did some work with a couple faith-based organizations, and just the rhetoric that went on about, again, even in political spaces, the eugenics sort of push that said, you know, we're killing our race and we can't do that, was enough for them to vote for a party without any sort of evidence that supported that. And even though there's supposed to be a separation of church and state, they may not get in the pulpit and say that. But when they're in, you know, the church dinner hall after lunch or after service, and they're having these meals and they're spitting the rhetoric to their congregation, that becomes reinforced within the community. And so the community who it is affecting the most is actually part of perpetuating that same sort of system that is inaccurate. And so that's a very interesting sort of lens to take and try to understand a little bit more.
There's if I can just add a third piece here, there's a very interesting question that's puzzled me a long time. I think we all agree here, we've already referenced Carole Mason and other people's, Dorothy Roberts. We know this is a racist society. We know the white supremacist groups that are very tied to the anti-abortion movement are deeply racist. We know that. But therefore, given this racism, one would think they would want Black and brown women to have abortions. In other words, they have demographic anxiety. I don't need to tell, Ophra can tell us about border issues and hysteria about anchor babies and so on. So in other words, given the hatred of Black and brown people, why do everything possible, not only to deny them abortions, but also family planning? In many states, including in Texas, money is taken away from family planning programs and given to crisis pregnancy centers. So this is sort of puzzling. And I don't have a good answer to that. I can speculate that this really shows us the institutional power of the anti-abortion movement. Yes, of course, I shouldn't say of course, but yes, ideally they'd like less Black and brown people being born, but the anti-abortion movement is going to stand for no abortion. They are an extraordinarily powerful element of the contemporary Republican Party. The Republican Party needs not only their money, but their troops, their rank and file. People who get up at 5 a.m. in cold Cincinnati weather and go stand in front of clinics. So that's just a sort of another weirdo part of this whole puzzle of the abortion, of the abortion landscape in this country now.
We have a question from a midwife and pro-choice nurse practitioner who asks, aside from medical abortion, how can we facilitate getting abortion out of medical hands? It seems to me we can't leave it in the hands of medicine. It needs to go not so much back underground, but back into hands of women and people with uteruses and ovaries. How can we help that to happen?
So I'll jump in. This goes back to doing research and supporting movements that are led by community. And so when the community is at the forefront, empowering those people within their community to fight for decisions and things that are best for them, then that's a way to get it back in the community. One of the things, again, going back to some of the preliminary data on the mistrust literature, if you give me access to a system that I don't trust, I am not going to go to that system. And so therefore I don't have access to that system. But I will go to the system that I trust, which is in my community. And so how do we empower people within the community to create these spaces within their community so that they can have the reproductive health supports that they need. And so what that looks like, I wish I had, that's the $1 million question of like, what does that actually look like? And I don't know, but I know that there is something to things being led by the community, for the people, by the people. That is really the direction that we need to go in. But I don't have like a way to, I don't have a like handbook of how do we make that happen. But I do know that there is power in community, and I agree 100% that this definitely needs to go back into the community. But how so? Particularly given the patriarchal system and the capitalist system, which makes sure that power is maintained in the hands of very few people. That's going to make this even more difficult outside of this. I want to say dismount. I really want to tear all the whole shit down, but I know that's not like I can't tear the whole system down, even though I want to. But I feel like that's what needs to happen in order for things to change.
I mean, there is a way. I mean, the good news is there is an answer to your question, Tamika. The bad news is it's not going to happen too soon.
Right.
Some of my colleagues at UCSF, in particular, Dan Grossman, who's a physician, and he's also the director of the research group I work in, Advancing New Standards in Reproductive Health. He has been pushing the idea of mifepristone over the counter. Now that would, if that came to pass, and that is a huge if, then people in the communities could set up workshops in the local community center, and people could tell other people, listen, you should take the first pill now, and then you should take the misoprostol 24 hours later. If mifepristone, I'm talking about somebody's idea of over the counter when 20 minutes ago we were talking about how they're going to withdraw FDA approval. So if you're hearing a certain disconnect, yeah. But so yes, that is division. It is not going to happen very soon, and it is to answer the question of to answer the two people who posed the question. Criminalization is a big issue, and we've used this word a number of times in the course of this discussion. Criminalization is a very serious issue. However, it won't take place at the same rate in all places. Ophra, I feel like every question I've been dumping on Texas, and my apologies, but someone who showed a very well-known case of a young Latina who showed up at a hospital in Texas. She had taken medication abortion drugs that, if I'm remembering the story correctly, she had gotten through, quote, illegal means, meaning she didn't get it from a clinic, but she showed up at a hospital emergency room, and somebody in that emergency room called the cops. She was put in jail for 2 days, and then they let her out saying, oh, wait a minute, Senate Bill 8, we don't go after the women. In some places, this criminalization will come down very hard. In other places, we've seen district attorneys and prosecutors saying, no, they're not going to prosecute for abortion cases. So it's not going to be, it's not going to be one solution fits all. And I'm very sympathetic to the people who asked that question. And I'm sympathetic to Tamika's desire for it. It is in a context, this can only happen if medication abortion drugs are readily available. People are not going to start doing, now the Jane Collective did, it's true, but I don't think in this context we're going to start seeing people doing procedural abortions, entering the uterus. It's just, in this legal climate, it's just too dangerous. So the vision of people helping people outside of medicine can only happen if mifepristone is not if approval is not withdrawn.
I would say though, Carole, that the other types of abortion, surgical abortions could be done by, for example, midwives and
Oh, by midwives, yeah, but we're talking
and
not medical, I mean, that's
right. But I think part of that is it's up to the AMA, the American Medical Association, and ACOG, the American College of Gynecologists, to sort of relinquish some of that control that they have over sort of the surgical abortion procedures.
well, we have, but Ophra, we have many states, probably not yours, but we have many states, you know, where nurse midwives, nurse practitioners, physician assistants, what some people refer to as, quote, advanced practice clinicians. I mean, these people are doing abortions. I mean, and it has been hugely helpful, and in terms of access. Colorado, a very mountainous state. You know, I talked to a Planned Parenthood director there a few years ago who said, you know, in some of her clinics, way up in the mountains, a doctor would come through only once a week. But once Colorado passed a law saying that nurse practitioners could give out medication abortion pills, it was, you know, a whole new ballgame. So I think the question as raised by the questioners was, how do we take it away from medical institutions?
Yeah, I guess they're I don't know if you would consider lay midwives as part of the medical establishment or not, but I think they're,
I would see them as a good option to have this done, but they would be taking great legal risk.
yes, for sure. I mean, we do need to not have criminalization. You're right.
I will
Absolutely.
drink to that.
Great. So as a final question for the night, we have, how would you advise someone who sees anti-abortion groups on campus trying to engage? What if I'd like to engage? How do you respond to the misinformation in an informed way without getting furious?
I mean, I always think having, you know, not arguing, you know, not being pedantic, but really asking people questions works quite well. You know, like, well, why do you think that? You know, do you know anyone who had an abortion, and what were their reasons?
How did she freeze? While she's being unfrozen, not to make her into Elsa, but while she's being unfrozen, I mean, following on what Ophra was saying, a few years ago, I think a journalist started asking anti-abortion people, how many years do you think women should go to jail for having an abortion? And that really changed the conversation. I mean, people stuttered. I didn't think about that, or I don't know. So, Ophra, are you back?
I'm back, but
Okay,
if you were
keep
talking,
going.
go ahead.
No, you go. You go.
I mean, I don't even know where I got frozen, but I was just saying, you know, how do you feel about the separation of church and state? Do you know anyone who had an abortion, and what was their story? How do you feel about the idea of bodily autonomy, right? And people being able to make decisions about their own bodies, and how does that correlate with other issues of bodily autonomy? You know, I mean, I think really getting people to think about the issues at a deeper level than the surface level misinformation, jargon and rhetoric. Abortion is murder, abortion's murder. But why do you think that? And is that an infringement on people's religious beliefs who don't believe that? And, you know, really asking questions and getting people to think more deeply, I think, is a great strategy. I don't know what you all said, but I'll agree with it.
I mean, I think that audience, I mean, when you have these groups on campus, it can be very performative. I don't think you're going to get, I mean, I love the questions you're posing, Ophra, And I could see in a controlled classroom environment, or, you know, that would work. When you have people on campus screaming and holding disgusting pictures, I don't think you're going to get reasoned responses. I think your target then are the people who are listening to them. And, you know, and I think the challenge, and it's not easy at all, you know, is, and I think it has to be people from a similar demographic. If it's undergrads doing this, you know, you want to have similar people talking to that. I mean, not talking to the protesters, but talking to those who are listening to them, saying, look, here's maybe having handouts. Here's a different way of thinking about these things. You know, give them information from the Turnaway study. Do you know that people who get the abortions they want do better than those they don't? And I think an incredibly powerful finding from that study, you know, is the issue of bonding better with their children, because people try to make those who are, to demonize people who have abortions. They're selfish, they don't care, they're murdering their baby, they don't like kids. I mean, some portion of abortion patients don't want children, and we respect that choice, but the majority do. 60% of abortion patients already have children. And the fact that getting an abortion makes them able to be better parents to the children they have, to me, is an extraordinary, powerful message to give people.
You're right. Like, we should probably just ignore, right? If there's people screaming, just ignore them. Like, don't give them attention, and have counter demonstrations showing that people really are pro-abortion also, you know, like, don't keep it stigmatized.
So I agree with both Ophra and Carole, and I just want to add, for me, so I come in contact with protesters quite a bit, both on campus and off campus, by sheer proximity of my location. And it took me a really, really long time not to engage. But as my colleagues have both suggested, the option to not engage is a very real and viable option. You do not have to engage with folks who are on campus or who are spreading falsities in that context. What I've learned about sort of combating misinformation is that, you know, it's particularly around like advocacy and support. Like, I think that there's this misconception that if I am an advocate and I'm fighting for this particular issue, that I have to be the one that's on the front lines, that I have to be the one holding the picket sign, that I have to be the one that is very, very vocal in spaces. And I would just challenge us to think beyond that. And so you can, even as something as may seem simple as having a conversation with someone to give them correct information, is as powerful as that person then going to share it with someone else. So take, for example, if you have someone who has some pretty conservative views that are different from yours, likely that conversation is going to not be welcomed. But if you share it with someone else that they may have a connection to, they may be more likely to listen to them. And so you may not see the direct effects of that, but it's still part of the movement of disseminating the correct information. The other thing that I think has been helpful for me is that I have learned to use my sociological imagination and recognizing that people come from different spaces, right? And that we all have different pieces of the puzzles that make up who we are. And so you can then sort of separate yourself in understanding where this person may come from. You don't have to agree where they come from, but understanding where they come from. And an example of that is that, so I was walking past a clinic, and we have tons of people that are out in front of the clinic. And there's a guy that was there, and he told me that I was going to hell. He thought I was actually going into the clinic, and he said, if you have an abortion, you're going to hell. And I looked at him And I didn't say anything at the time because at that point in my space, I was like, do not engage, do not engage, do not engage. Well, I saw that same individual at the soup kitchen that I volunteered for. And so that really actually gave me some perspective about this individual in particular, is that, well, one, it pissed me off because they're exploiting people, right? They're paying them to be there on the street. But at the same time, I recognize he had to make a decision of, do I get money so that I can eat, or do I fight for something that perhaps isn't actually in the best interest of my people? Well, I want to eat. And so that to me painted more of a human picture where I don't agree with what he's saying or doing. But I was less, I don't want to say upset, but I was less reactive because I recognized that he was coming from a very, very different space. So I try to use the notion of seeing history and biography and social structure and how they all intersect and interlock to formulate our individual lives, meaning that what that person brought up with is greatly informing their opinion. And so I'm going to disconnect from the personal. When I keep it personal, like, he told me I was going to hell, I get really pissed off. And I'm like, that's not the correct picture. That's not that. And I've wasted precious time and I've wasted precious energy. But if I can go in another space and have a conversation with someone who may have a conversation with someone else, and that person may have a conversation to someone else, I may not see those tangible, more intermediate, like quick fixes, but I will, that is absolutely effective as well. So just know when you're trying to affect change and you're trying to make sure that information is there, there are more ways that you can do it than just simply countering someone else. In fact, when you counter someone else, that is probably less effective than it is. They say, what is the thing? Don't raise your voice, perfect your argument. And so focusing on that and in spaces that have fertile ground, I think are important things to do when you're fighting for a movement.
Great. Thank you all to all of our panelists for a really fantastic and very engaging discussion. The recording of the discussion will be posted on the center's YouTube page, so I encourage folks to go there and share it with anyone who may be interested. So thank you everyone again for coming, and I hope you have a great night.
Thank you all so much. This was
Thank you.
fantastic. Thank
Thank
you.
you for inviting us. Very nice to see you, Tamika and Ophra, and nice to meet you, Theo. And
Yes,
nice to
good seeing you all.
Thank you all.